Good morning, everybody. Welcome to a class on perioperative stroke. Perioperative stroke can be defined as stroke occurring during surgery or within 30 days postoperatively. It occurs in roughly about 0.1% to 1% of most non-cardiac and non-neurological surgeries, but it increases to about 5% to 10% in high-risk surgeries such as cardiac or major vascular procedures. The risk factors of perioperative stroke can be an increasing in age, mostly above the age of 65 years, and it increases maximum to the patient who has 85 years and above. If a patient has hypertension, diabetes, and chronic kidney disease, this can amplify the risk by promoting atherosclerosis and endothelial dysfunction. Female sex have a higher perioperative stroke risk because of accelerated postmenopausal atherosclerosis. The other causes which can lead to stroke are atrial fibrillation, left ventricular thrombus, or severe heart failure. And when a patient has perioperative anticoagulation, which is interrupted, that can be a significant risk factor for stroke. And if a patient has significant carotid stenosis, especially if high grade and symptomatic. Patient may have patent foraminal veil, which may increase a stroke risk via the paradoxical embolism. And a patient with migraine may have heightened cerebrovascular reactivity, and this can lead to prothrombotic mechanisms, which might lead to a slight increase in perioperative stroke risk. The procedure-related factors, cardiac surgeries, especially coronary artery bypass grafting, and valve replacements have a high perioperative stroke risk. This is around 1 to 3%, and if a patient is undergoing complex aortic arch procedures, this can increase to above 5%. A patient undergoing cardiopulmonary bypass may have an increased stroke risk because of the pro-inflammatory and hypercoagulable state. Open aortic aneurysm repair or carotid revascularization also carries an elevated stroke risk due to a direct vascular manipulation and potential plaque embolization. Neurosurgical procedures due to intravascular vascular manipulation may have some of the highest perioperative stroke risks. For example, a patient undergoing clipping or coiling of unruptured aneurysm may have stroke risk up to the extent of 5 to 12%, as well as a risk of intracranial hemorrhage. A resection of an intracranial glioma may have a stroke risk at the order of 12% to 16%. And a perioperative stroke risk index indicates that the patient with greater than 5 of these key risk factors, that is an age greater than 62 years, history of stroke, chronic lung disease like COPD, and renal failure, has a high stroke risk. If a patient has patent foraminal veil, if a sudden increase in intrathoracic pressure or venous thrombus formation may occur. This can lead to paradoxical arterial embolus during or after surgery. Hypoperfusion due to the clamping of large arteries or excessive anesthetic debt can reduce the cerebral blood flow. This may cause watershed or global ischemia in the brain, and especially in a patient with pre-existing cerebral vascular stenosis or patient with poor collateral circulation. Therefore, the perioperative hemorrhagic stroke may also occur from surgical manipulation, anticoagulation, postoperative hypertension, or pre-existing intracranial lesions. So how do we assess a patient for the possible development of stroke prior to surgery? If a patient has ischemic stroke or TIA, then the elective procedure should ideally be delayed for at least 6 months. And if a patient absolutely needs to undergo carotid revascularization surgery, acute coronary interventions, and procedures for infective endocarditis, then these are exceptions to this rule. A patient with a recent symptomatic carotid stenosis greater than 70% should be considered for carotid revascularization before any other major elective surgeries. However, if a patient is asymptomatic, then this prophylactic carotid revascularization is discouraged unless there is specific clinical scenarios such as contralateral occlusion of one of the major arteries of the brain. If a patient has a history of prior stroke or carotid bruit, which suggests an arterial disease, this falls into the category of high stroke risk individuals. So you will have to do a focused preoperative neurological evaluation and carotid imaging study, such as ultrasound or magnetic resonance angiogram. This is done to guide the perioperative management. The optimal management strategy for asymptomatic carotid stenosis is being conducted in the trial known as a CREST-2 trial. Here they want to compare medical therapy versus prophylactic intervention for asymptomatic carotid stenosis. The CREST-2 trial stands for the Carotid Revascularization and Medical Management for Asymptomatic Carotid Stenosis. This is a study comparing intensive medical management alone versus revascularization, either carotid endarterectomy or carotid artery stenting plus intensive medical management to determine the best way to prevent stroke in people with high-grade asymptomatic carotid stenosis. The CREST-2 trial involves men and women aged 35 and older who have a high-grade stenosis of greater than 70% in at least one carotid artery, but no symptoms of stroke or transient ischemic attack. Here, they compare revascularization versus intensive medical management alone. The participants are randomly assigned into one of the two comparisons. That is, the trial 1 is the intensive medical management plus carotid endarterectomy versus IMM alone. The trial 2 was IAM plus carotid artery stenting versus IMM alone. What are the possible mechanisms of perioperative stroke by the time of occurrence? So, intraoperatively, the patient may develop stroke due to embolic events from the cardiac or the aortic manipulation, or due to hyperperfusion due to hypotension or vessel clamping. Whereas postoperatively, the patient may develop new onset atrial fibrillation, myocardial infarction, prothrombotic state, hemodynamic instability, and sepsis, or surgical complications. In medication management, in patients who have been taking aspirin for secondary stroke prevention due to prior ischemic stroke or transient ischemic attack, the plan is to continue aspirin throughout the perioperative period, unless the surgery has a significant bleeding risk, such as intracranial surgeries, spinal surgeries, or major oncological surgeries. Whereas in all other cases, the aspirin is discontinued for about 7 days preoperatively. If the patient is getting dual antiplatelet therapy for intracranial stent or carotid stenting, the elective surgery should be ideally deferred for at least 6 months post-stent placement. And if a patient is getting clopidogrel, they are withheld for 5 to 7 days preoperatively. Coming to the POISE trial, this is the decision to initiate aspirin de novo perioperatively for primary cardiovascular prevention is not advised due to increased bleeding risk without clear benefit. This was an international study testing perioperative low-dose aspirin and low-dose clonidine in patients undergoing non-cardiac surgery to prevent cardiovascular events. The perioperative aspirin has shown not to reduce the risk of death or MI, but it significantly increased the risk of major bleeding. Low-dose clonidine also did not reduce cardiovascular events, but increased the risk of hypotension. The POISE-2 trials to evaluate the effect of perioperative aspirin and clonidine on the 30-day risk of death or non-fatal MI. So here the design was a 2x2 factorial randomized controlled trial in which the patients are assigned to one of the 4 groups, that is aspirin and clonidine together, aspirin and clonidine placebo, aspirin placebo and clonidine, and aspirin placebo and clonidine placebo. Here they found out that the perioperative withdrawal of chronic aspirin therapy did not increase cardiovascular or vascular occlusive complications. So if a patient comes to you with a number of risk factors, and you will have to assess whether the patient might develop a stroke perioperatively, we would have to screen such a patient. We would screen a patient can be considered, that is, if all the patients can be screened for the risk of developing stroke, but there are a few patients where it is strongly recommended that you screen the patient for stroke, such as a patient greater than 65 years of age and with a history of stroke or TIA, left main coronary artery stenosis, peripheral vascular disease, history of cigarette smoking, carotid bruit, previous carotid surgery, or diabetes. Now, if a patient is on vitamin K antagonists such as warfarin or direct oral anticoagulants for atrial fibrillation, or a patient has mechanical heart valve requiring individualized planning. All of this require individualized planning. The warfarin is stopped 5 days prior and direct oral anticoagulants 2 to 3 days prior, depending on the renal function. You will have to bridge the warfarin therapy with parenteral anticoagulants with low molecular weight heparin for patients who have a high thrombotic risk, those with mechanical mitral valves, and recent thromboembolism or antiphospholipid syndrome. The routine bridging in patients with low risk is unnecessary, and it may increase bleeding without reducing the thrombotic risk. So here what you have is a Watchman device in a patient with atrial fibrillation who is not able to tolerate or long-term anticoagulation. This is a non-pharmacological stroke prevention strategy where a device is placed in the left atrium. Beta blockers can be considered if the patient has been taking beta blockers preoperatively, and if the patient has not got beta blockers preoperatively in low doses, it is discouraged because of increased stroke risk from perioperative hypertension. But if the patient has been constantly getting beta blocker therapy, then it should be continued to avoid withdrawal. Coming to the use of statins, the perioperative statin use decreases postoperative cardiac complications, but it does not significantly reduce perioperative stroke incidence. Coming to the anesthetic management, our goal as anesthetists is to maintain cerebral perfusion and to minimize embolic risk during surgery. Uh, Though we know that prolonged hypertension is known to cause end-organ injury, including stroke, randomized trials evaluating the use of intravenous vasopressors to target higher intraoperative blood pressures have yielded neutral results, and some even have demonstrated harm. But more recent evidence has indicated that we have to avoid hypertension and we have to ensure stable cerebral perfusion. The current guidelines recommend that we have to correct the hypertension and to maintain a mean arterial pressure between 60 and 65 millimeters of mercury during cardiac bypass. But if a patient has a cerebrovascular injury, then a higher mean arterial pressure targets will be needed. Coming to the surgical techniques, if a patient is undergoing off-pump coronary bypass grafting and no-touch techniques in order to minimize direct aortic manipulation, it has been seen that the no-touch approach reduces the stroke incidence. Whereas certain surgical positions and management strategies in non-cardiac surgery may affect the cerebral perfusion, increasing the stroke risk, such as a beach chair position seen in shoulder surgery, because it reduces cerebral perfusion pressures. It is necessary to carry out neurophysiological monitoring, such as somatosensory evoked potential, motor work potential, EEG monitoring, as well as transcranial Doppler ultrasound, because it can rapidly identify cerebral or spinal cord ischemia and to detect microemboli. Postoperatively, how will you have to detect whether the patient has stroke? It may be a little difficult to identify whether the patient has stroke immediate postoperatively because of residual anesthesia, sedation from prolonged intubation, postoperative pain medications, as well as stroke-induced alterations in consciousness. So we will have to do a basic neurological assessment at each postoperative evaluation. And we will have to do a focused neurological exam every 2 to 4 hours during the first 24 hours after surgery. And we will have to do the face, arm, speech time screening tool, or we can use a modified National Institute of Health stroke scale adapted for the bedside use. So if you can see here, the National Institute of Health stroke scale has 11 parameters, which contains the level of consciousness, orientation questions, response to commands, gaze, visual fields, facial movement, motor function, that is of the arm and in the leg, limb ataxia, sensory, language, articulation, and extension or inattention. The stroke severity can be measured as 1 to 4 having minor stroke, 5 to 15 having moderate stroke, 16 to 20 having moderate to severe stroke, and 21 to 42 having severe stroke. It is important to monitor for atrial fibrillation perioperatively, and the presence of atrial fibrillation increases the risk of stroke, most commonly after cardiac surgery and less frequent after non-cardiac surgeries. The surgery-related risk factors are hypovolemia, intraoperative hypotension, anemia, trauma, and metabolic disturbances, with cardiac and thoracic surgeries carrying the greater risk. There are some validated clinical risk scores such as a CHA S2 VAS score, HAT score, POAF score, and the COM-AF score. These can stratify patients who benefit most from continuous telemetry or prolonged rhythm monitoring. So when would you restart the antithrombotics after surgery? So this requires careful consideration of both the thrombotic and the bleeding risk. There are current guidelines from the American College of Surgeons, Canadian Cardiovascular Society, and American College of Cardiology. They recommend restarting anticoagulation 24 hours postoperatively after low bleeding risk procedures and between 48 and 72 hours postoperatively after high bleeding risk procedures, provided we get adequate hemostasis by the surgery team. A patient who has a high bleeding risk has to meet criteria such as the annual major bleed risk greater than 4% as per the ARC HBR consensus, or the has blood stroke greater than 3%, greater than 3. So we will have to use strategies such as optimizing modifiable risk factors. We have to decide whether to start the dual antiplatelet therapy. We have to do a selective use of perioperative bridging therapy, as well as a delayed anticoagulation restart when the hemorrhagic risk significantly exceeds the thrombotic risk. So all of these help in reducing the perioperative bleeding complications while ensuring adequate protection against thrombotic events. So let's say, for example, the patient has a suspected stroke. We will have to first identify during an MRI to find out whether this is a large vessel occlusion or a small vessel occlusion. If it is not a large vessel occlusion, then we have to assess whether the surgery was minor or if it was more than 14 days have passed since the surgery. If negative for both, we have to consider antiplatelet agents within 24 hours if there are no contraindications. If the surgery was minor or more than 14 days have passed, then you can consider intravenous thrombolysis if there is no contraindication. However, if it is a large vessel occlusion, then we can consider mechanical thrombectomy if there is no contraindication otherwise. The management of perioperative stroke is quite challenging because of the bleeding risk associated with the recent surgery. So, like I mentioned, intravenous thrombolysis is contraindicated within 14 days of major surgery. However, if the patient has undergone intracranial or intraspinal surgery within the past 3 months, intravenous thrombolysis remains contraindicated. If the patient does not have to undergo mechanical thrombectomy nor intravenous thrombolysis, then you can initiate antiplatelet therapy within 24 hours. So in conclusion, there is effective prevention and management is important to comprehensively treat the patient. We have to do a comprehensive preoperative assessment and optimization. We have to take procedure-specific intraoperative precautions to maintain the cerebral perfusion and to minimize embolic risks. And systemic postoperative monitoring is required for early stroke detection and intervention.